The following podcast is part of a certified educational activity titled Critical Conversations for Surgeons and Oncologists in Resectable Gastric and Gastroesophageal Junction Cancer. Expert guidance on integrating rapidly evolving evidence for immunotherapy platforms. Access the entire activity and complete the post-test at peerview.com/DPV860. Downloadable slides and practice aids are also available.
Welcome, everyone, to the afternoon symposium. We're going to be talking about critical conversations for surgeons and oncologists in resectable gastric and GE junction cancer.
Hi, everyone. Thanks for the invitation. My name is Yelena Janjigian. I am the Chief of GI Oncology Service at Memorial Sloan Kettering, and my lab and research focus is heavily in upper GI tumors, including esophageal cancer. We've been able to bring immunotherapy in this disease, both in metastatic and now locally advanced tumors. So I'm excited to be here to just start the discussion with you about, what your comfort level is with using perioperative therapies, particularly a triplet combination with immune checkpoint blockade. So it's thanks, Siva, for having me.
So I'm Siva Raja. I'm the Director of Esophageal Surgery at the Cleveland Clinic. Thank you for joining us this afternoon. So the goals for today are to improve our understanding of the emerging clinical evidence supporting the use of immunotherapy platforms in resectable gastric and GE junction cancer. To equip you with strategies to construct evidence-based treatment plans with immunotherapy regimens in the surgical setting, and lastly, to provide practical guidance on how to address safety, dosing, scheduling, and other treatment delivery considerations when implementing immunotherapy programs. We will attempt to do this in the form of a mini tumor board at the end. So we have a few cases that we've picked out. So the incidence of gastric cancer, like many cancers, are increasing, and on the far side is the projected incidences based on what the rate of increase would be. But regardless, by 2025, we are expecting to have about 705,000 patients worldwide, not just North America, and 476,000 patients in esophageal cancer worldwide die from this disease. As a result, it is an opportunity to significantly improve their outcomes with multimodality therapy. So in the beginning, I'm going to talk about challenges in treatment of resectable gastric and GE junction cancer, and then from that, we'll move on to immunotherapy. So in my mind, when I was asked to think about this, I think about the challenges in these four types. The perception of poor prognosis for this cancer, many people seem to think of it as a terminal disease rather than a curable disease. The FLOT, which is a very commonly used regimen now, is historically and even currently has a perception of substantial toxicity. We're going to talk about what that actually is. And the challenges in the United States has a lot to do with also decentralization of surgical care in the United States. And along those lines, also possibly oncologic care. And lastly is access to immunotherapy. It's only in the last 4 years or so that verbiage has been in our vocabulary as it pertains to resectable GE junction and esophageal cancer. So how does this poor prognosis come to play? The operations for esophageal cancer have existed since the 1950s, and until possibly the 90s, the mortality of the surgery was almost, if not, it was just under the mortality of the disease process itself. So the question used to be, do you want to die of the cancer or do you want to die of the operation? But since then, we've made substantial progress in the management of this cancer, both surgically as well as from an oncology standpoint. And this is the Walsh trial many of you would be familiar with. In 1996 New England Journal paper was the first study to show that you could improve the outcomes using multimodality therapy in addition to surgery. Now, there are a lot of problems with this study, and as a result, it never really had traction. And until we came to 2012 and to this landmark New England Journal paper, which we refer to as the CROSS trial. The CROSS trial showed us that we can the surgical outcomes were also pretty good, but also that the addition of chemoradiotherapy using their protocol substantially improved survival. Now, the overall survival shown on the far side of the screen is about all comers, adeno and squamous. Now we know that they are not the same disease processes. They're put together for anatomic reasons, not necessarily for biological reasons. A lot of the benefit actually was noted in the squamous cell arm and not so much in the adenocarcinoma. But still, there was a difference. So adenocarcinoma in 5 years, they had a 47% 5-year survival, and surgery alone had a 33%. That is a noticeable difference, and it's a meaningful difference in our patients. From there, we wanted to address some of the weaknesses of that, in that cross-trial seemed to be very good at local control and somewhat okay with distal control. And as a result, we were never happy with the oncologic regimen. So until FLOT, there's FLOT 4 and then ESOPEC. In this interest of time, I'm just going to skip to the end of this, which is ESOPEC, was looking at chemotherapy to address the issue of distant failure. Now, this is an issue where the FLOT versus cross, they showed a 7% difference. If you were a pro-FLOT person, you would say this is a significant difference. If you were a radiation oncologist, often you would say, wait a minute, the cross trial had a 55% 3-year survival. You're only having 51% here. So maybe, for some reason in your arm, in your study, the cross did not do well. Maybe you didn't deliver it well. Regardless, I think that there was a difference, both in terms of 3 years overall survival as well as with PathCR. So this is one of the first areas for us to address recurrence-free survival, because even though we were curing disease locally, we weren't curing them of their distant metastatic disease. And that's where this study showed that the local, and regional metastatic control or disease control was equivalent between the studies. All of the difference really came down from the significantly decreased distant recurrences. So this is sort of where we were. But once again, in these studies, are they comparable cohorts? Well, this is where the perceived toxicity of FLOT comes in. So FLOT is associated with, at least our perception is associated with a higher adverse event profile compared to cross. This is probably true. FLOT, 71% completed the entire regimen compared to 92% of cross. Now, if you're a classes half full kind of person, you would say, wow, if FLOT gave you this much of a difference when most people didn't finish it, what would happen if you can actually get everyone through this? That's the argument that I would make. But there were other issues with, as in any study, is that the study and real life don't always go together. The median age of this population was 63, and many of them were reasonably fit, and that's where these people went through it. And of course, you have to also take into account is that where are these voices? There are established pathways in most hospitals, care paths, that involve radiation oncology. Chemoradiation is well entrenched in our thought process as something that is well tolerated. So even if there's a slight decrease in survival or recurrence-free survival, people are willing to take that chance to get their patients through it. But if you look at a real-world study, this is a recent publication from Ujira, Netu Interpol's baby there, looking at patients undergoing esophagectomies worldwide. They're looking at an older population, 66 as a median age. More than 90% were ASA class 2 or 3, and any comorbidity. 2/3 of the patient had some comorbidity. So we're actually in real world looking at a more sicker population. So having talked about what our perceptions are about this, this is the reality in North America. And many groups, including the STS database, have published on this, is that any operation that one does, you get better at it the more you do. And most in the United States would consider 20 esophagectomies for an institution, not per person, not per surgeon, but for institution as a high volume center. And if you look at NCDB analyses, only about 1% of hospitals meet that criteria, which means that 99% of hospitals performing esophagectomies in the United States are under 20 cases per year. Looking at the STS one that was published, now this is 10 years old, I'll give you that. Maybe it's gotten better, but it hasn't gotten dramatically better. The median in the STS submitting hospitals, 167, was 5 esophagectomies for cancer per year. Yeah. So that's, and since most of them don't necessarily have 10 surgeons in the group, maybe 1 or 2 per year is pretty much what's being done. That being said, high volume institutions do account for about 13% of all esophagectomies, but 87 are done in these lower volume institutions. So with the outcomes being in question in most hospitals that are performing them, then it comes to the last aspect of immunotherapy, which is the current the additional pillar in therapy. You know, we had chemo, we have radiation, we had surgery, and we have immunotherapy. There are issues with the access to immunotherapy, and that's at least the perception. The perception often rises from reality, meaning that at some point during the course of this, it was difficult to get immunotherapy. I'm not saying it is now necessarily. So integration of immunotherapy in the community has been variable. Now, it's gotten better as the time's gone on, but it is variable. Until recently, chemoradiotherapy with residual disease was a point of entry for immunotherapy based on the Checkmate 577 trial. As a result, so even when a patient during tumor board, this was a common point of discussion, was that, hey, this patient may benefit from immunotherapy, but we can't get immunotherapy if they've gotten chemotherapy. So we have to do chemoradiotherapy and have residual. If they have residual disease, then they can move on. So accessing immunotherapy actually became a goal, and as a result, FLOT initially was not as popular. And most community oncologists are not aware as of yet that neoadjuvant immunotherapy in the form of Matterhorn trial is actually approved in the NCCN guidelines. And with recent OS data, people can sometimes get confused between Matterhorn and Checkmate 577. So while all of us in this room firmly believe that immunotherapy has a role in the treatment of GE junction and esophageal cancer, the access and the practical delivery of that is often not as smooth as we would want it to be. So how do we take this to the next level? I think that given there's so many moving parts for the treatment of this disease, including oncologists, thoracic surgeons, surgical oncologists, as sometimes these are more gastric than cardiac, and then esophageal. Radiation oncology still has a role, and gastroenterology in identifying patients who still have the disease. So this multidisciplinary approach is what is necessary for this cancer to have the optimum outcome. So when I look at a patient, I think about two things. I tell everybody, there's an optimum therapy for you, and then there's the optimum therapy that you can handle. And so we first do the staging that is necessary for this, including a multidisciplinary evaluation with CT scans, PET scans, endoscopic ultrasound, as well as looking at functional data to figure out, are they fit for surgery? We start with as surgeons, we tend to be a little bit more simplistic. You got to pass the eyeball test for me to even worry about getting a stress test. You could have a great stress test at normal pulmonary functions, but you come in a stretcher, you're not getting an operation. So, review of their comorbidities and evaluation of the nutritional status are very important. And then once they're done with their induction therapy, a lot of this has to be redone because this person that you saw in the hospital, in the clinic before all this started is often not the same person that you're seeing, after the treatment's been done. So a reevaluation is also an important part of this. And lastly, before I move on, there's surgical considerations. The location of the cancer makes a huge difference. There are certain locations you can do whatever you want in terms of approach. You can do a McEwen, you can do an Ivor Lewis, you can do a Sweets, you can even do a total gastrectomy with a thoracic Roux-en-Y. All of them will work, but in some scenarios, certain things are necessary. And the way things are going, I now, like everybody else, start thinking about cancers of squamous cell cancer as a different disease than adenocarcinoma. So I think ultimately we're going to see that pan out. But for now, when I see a large cardiac cancer, I treat it as much as gastric cancer, and I use diagnostic laparoscopy liberally. Now, I use this not only to figure out if they have metastatic disease, but I also use this to figure out if what operation is necessary. Often the gastroenterologist evaluation of the cancer inside is not reflective of the cancer on the outside. So it's easy for them to say you have a GE junction cancer and give you a treatment. And then when we go to operate, it turns out that it's actually a significant gastric cancer.
The question about Matterhorn and Checkmate 577 and CROSS comes up quite frequently. I think one caveat about CROSS and ESOPEC is that the historic CROSS regimen included patients with squamous cell cancer. That's the initial CROSS study. So when you're interpreting these results, you have to understand that squamous cell cancers are completely different. That has nothing to do with the slide, by the way. I'm just giving you my perspective. And adenocarcinoma patients is what we deal with in the clinic more frequently. And when you see a squamous patient, it's definitely reasonable to consider chemoradiation, but not for adenocarcinoma. We do know that radiation changes the tumor microenvironment, and some of these papers that were initially published from Checkmate 577 studies show the increase in PD-L1 overexpression in the primary tumor with radiation. But I think that point is relatively minor because with good surgeons available, and again, I strongly agree with a need for subspecialty and focusing the right. Doing an esophagectomy is a privilege, not a right, sort of idea. Who cares about the PD-L1 overexpression in the primary tumor? You're going to remove it, right? So the game is lost and won in the systemic arena. And we do know that whether or not you give immunotherapy before surgery or after surgery matters quite a bit. The data in melanoma, renal cell cancer, lung cancer, all pans out, and now gastroesophageal cancer, that when the primary tumor is in place and the patient is the most fit, you have a greater chance of impacting their anti-tumor T-cell response. And you want those cells to help you suppress the micrometastasis after the surgery while the tumor is already gone, but the patient is still recovering and maybe not yet fit for additional therapy. So the rationale for adjuvant immunotherapy is listed here on the top, and the rationale for neoadjuvant therapy, again, as you see here, there's many more immune factors at play while the tumor is in place to mount the most robust immune system response. So Checkmate 577 was an opportunistic sort of question whether or not patients with residual disease after 5 doses of carboplatin, paclitaxel, and radiation, so not very much systemic therapy. And if they have residual node-positive disease or tumor residual disease, they would get this high-risk population, get randomized against placebo or adjuvant nivolumab. And the disease-free survival is improved, and not surprisingly, because those patients essentially are like stage 4 disease, right? Because those patients, node-positive disease, you know that they will recur within a year, and it's the most heartbreaking thing. You got them through this really difficult operation. They went home safe. They're eating, they're, fit. You put in so much hard work in getting them put together, and then their cancer recurs. So I understand sort of in principle why we would want to treat those patients. But you have to remember that Nivo is actually FDA approved in metastatic setting. So the way that I always thought about 577 is nivolumab now or nivolumab later. And, of course, we don't want our patients recurring, so doing it early makes a lot of sense, but it turns out that if you look at, and of course the metastasis-free survival improved, but turns out if you look at overall survival, the hazard ratio is 0.85, and it's not statistically significant. So that certainly highlights the importance of further biomarker selection in this population of patients. If you selected by PD-L1 overexpression by using combined positivity score, so both the stroma and the tumor positivity score, unlike lung cancer where it's just the tumor, the survival benefit was there. So how do I think about Checkmate 577 is that chemoradiation is okay, but not great. Remember, those patients also included squamous cells. So this was a very, old school study. We don't do adeno and squamous in the same study anymore. And if you see a study being offered to you to open at your center, you should tell them to rewrite it or pass on it in that. It's not the right way to treat these patients. So Keynote 585 tried to answer a question, and this was mostly an Asia study and very complicated sort of typical Merck study where, they were trying to answer 5 hypotheses with a relatively small sample size, 800 patients. And this was using a doublet cisplatin-based chemo. We know the type of backbone of chemo matters, right? Cisplatin is not good for your T cells because you get higher doses of steroids with it. It's a very toxic regimen. I have never used it in my practice, and I've been in practice for 20 years, 15 years. So using doublet regimen is a very sort of, Asia approach to adenocarcinoma, and it's not the way that is supporting the immune system in the best way. And they asked too many questions. They basically split the alpha in between PathCR, EFS, and OS. And in the end, they saw a signal, but that did not meet statistical significance. So the Pembro group did improve the complete response rate, but the placebo obviously did really atrocious compared to what we would see. But even the FLOD group underperformed for whatever reason, but it was a smaller sort of cohort than what we saw. So in the end, even though the curves did separate, and you see they separate relatively early, this p-value, because of the alpha and the way that it was split, was not statistically significant, and there was no OS benefit. So we do think, and we know now, and this is the first time that it's been demonstrated, that we could use complete response rate to help guide sort of the likelihood that the study will be positive for survival. Whether or not you should use it to guide whether or not the patient gets adjuvant therapy, that maybe we can discuss in the Q&A session. But I think in short, no, probably not. So, and then, again, for the researchers in the room, it's not always bad to go second, because you can learn on the mistakes that the first study made. In fact, when the AstraZeneca, board was trying to decide whether or not, when we were trying to sell this idea of the study, I remember Jose Vaselga at the time said, why would we do a study? Merck is already doing it. And they were a year into it, but they were doing it wrong. So we did it this way. We used a very simple hypothesis that addition of durvalumab will improve event-free survival. We didn't split the hypothesis too many ways. And then we used secondary as OS. By the way, OS data will be at ESMO this year. So, we will get the final say whether or not, long-term it improves survival. But as you know, and this was at ASCO plenary, we presented this in front of a stadium of oncologists and pharma, and hopefully some surgeons, because this is a big deal. This is the first study to show that immunotherapy works in early-stage gastroesophageal cancer. And patients were enrolled irrespective of PD-L1, but only adenocarcinoma patients, and only patients who were able to have an R0 resection. We did not mandate laparoscopies, and this was the first study to enroll patients globally. So we didn't piecemeal it just to say in Asia people will get doublet, in US they'll get triplet. We did it globally, and what we've seen from multiple data cuts that US doctors can give FLOT. In fact, the delivery of FLOT, at least at these centers who opened this study, and we opened it in multiple sites in the United States, the delivery of FLOT and the surgical outcomes were quite good. Of course, FLOT was born in Germany, and then Germans always claim that they're the only ones who can give it. That's not the case. Also, the Asians did it okay. We convinced. So in Asia, gastric cancer is like ovarian cancer in the United States, where the surgeons really mostly treat it. And historically, they wanted to just write everyone for oral form of chemo and just send them on their way. But we've convinced now South Koreans and Japanese colleagues, and increasingly even China, to now give FLOT, because they understand that that's the better systemic therapy, right? If you're going to take your patient to the OR and take, half of their organs out, you need to really make sure that they're not going to recur. And systemic disease, not local therapy. If you know what you're doing, and, some of these abstracts upcoming are kind of concerning, but if you know what you're doing and how to select the patient, you can get your patient through an R0 resection, or at least probably people in this room. And I'm really confident in that. And so then where they fail in the peritoneum, they fail in the liver, lung, bone. So what we demonstrated is actually R0 resection rate, at least in this cohort, is not compromised by addition of durvalumab. It was exactly the same in both groups, 92%. And this did not mandate laparoscopy. I can tell you the patients that were non-R0 were almost always the people that were surprised to find a more advanced tumor because the laparoscopy was not done at baseline. So if you're ever questioning, and if there's a gastric cardia extension, you really need to laparoscope these patients and take a look. The delivery of neoadjuvant therapy was very good. because these patients have all, they're able to eat mostly, they're able to tolerate it. But the key for this study were twofold. One, we got the surgeons involved early on. Daniela Milena was, I got her on the steering committee, and other surgeons from other locations. The study was open in 20 countries worldwide. And two, we made the chemo dose reduction interruptions very liberal. We said, whatever you want to do, you get to do, because we trust you, you know how to deliver chemo, right? And as a result, people were able to deliver perioperative chemo, right? We gave them general guidelines, when to give growth factor support, when to give hydration or antiemetics, but the rest we left it up to the investigators. And what's interesting, actually, in adjuvant setting, a pretty good proportion, 3/4 of them, were able to complete any components of FLOT, and more than half of them, 52%, were able to complete a year of adjuvant durvalumab, because that's, so the typical approach, you give 4 cycles of FLOT before with durvalumab once a month, you get surgery, you get 4 more cycles of chemo, and then 10 more cycles of durvalumab. So it's quite a big of a time investment. The majority of the patients were enrolled outside of Asia, but we had 19% of patients in Asia. The other thing, and when people say, oh, the CROSS, trial did so much better, they had very few T4 disease patients, if you look at the original New England Journal of Medicine paper, and a very low nodal stage. So they were cherry picking, and again, with squamous cell, different biology, right? Here we had 1/3 of G junction patients, so this is very representative of what you and I see in the United States, right? Most of our tumors are G junction, and the scary thing is G junction adenocarcinomas are on the rise globally. For the first time, when I traveled to Asia and looking at these subset cohorts, we're seeing adenocarcinoma of distal esophagus in G junction, where historically it's always been gastric cancer. And nodal disease, 70% of patients had nodal disease, which is clinically, again. And the other interesting point that I want to draw your attention, MSI tumors were rare, and PD-L1 overexpression using TAP criteria was seen in most of the patients. And that'll be important, especially as you're, deciding what to do for the patients. And these were the curves that changed the practice. It was never gets old to look at them. We saw an early and sustained separation, as early as 3 months separation in the survival curves, and a plateau, right? So, for these IO trials, for the trainees in the room, usually what we look at is not just the median delta, right, of EFS, but also how durable are this effect, and is there a plateau? Are you curing some patients? And you definitely are with this regimen. 24 months event-free survival is 67 versus 59%. All the subgroup analysis, including patients greater than 65. The age range in the study, the younger patient was in their 20s, and the oldest patient was an octogenarian. We had a bunch of octogenarians in their 80s. And even in older patients, there's a benefit for addition of durvalumab to FLOT. This diffuse gastric cancer hazard ratio always confuses patients. Well, we know that diffuse histology is not always characterized in each site, and WHO came up with some guidelines, but it's not standard. And so a lot of this diffuse histology was done not centrally. So we're looking at this carefully. But it's true, when you're doing your esophagectomies, if you see this diffuse histology with one of those tumors that extend from G junction all the way into the stomach, the radial margin will be positive possibly. And those are the people that you really need to, and we can discuss them after, do a more protracted course of chemo. They're not the same. So if you approach every single patient the same way, you will get burned. So you have to think about these patients carefully. The OS was already separating, and you'll see the updates at ESMO, but hazard ratio of 0.78 and p-value of 0.25, but this significant threshold was not yet reached at this analysis because it's early. Pathologic complete response are improved, and we can talk about, what does the future look for non-operative management, especially for patients who may have comorbidities or you're a little nervous about their recovery in the surgery. Question comes up, my tumor is out, why do I need to get more therapy, right? Disease-free survival, even in patients, and the difference between event-free survival, it's an intent to treat population, everyone you're randomized. Disease-free survival is population of patients that went through R0 resection and are truly cured, after surgery. And there's improvement in addition of durvalumab in those patients as well. 2-year disease-free survival of 75% versus 66%. In terms of delivery, we are not dogmatic. Most of my patients get a dose reduction of some sort, especially for neuropathy or nausea or vomiting. Our approach is that we see them relatively frequently early on, even if it's a televisit. I would say 50% of my patients are not being treated right in the same building that I am in. We have 7 satellites, as Matt will tell you, all over, the New Jersey and New York area, and they're often getting treated there. But just eyeballing them, talking to them, having your nurse just call them and saying like, "Hey, are you taking your nausea meds?" Does a lot of the support. And you can deliver FLOT into those patients if you're doing that. The most common adverse events are definitely chemotherapy related. So if you look at the grade 3, 4, or even any grade 3, any adverse events, the numbers are almost equivalent between FLOT, placebo versus FLOT durva, and it's because it's chemo side effects. So they get alopecia, the hair will fall out possibly, but it'll all come back. They get neuropathy, nausea, vomiting, and dehydration. The durvalumab adverse events are immune-related commonly, they're the common side effects that are a little confusing for oncologists to figure out whether or not it's immunotherapy or chemo is the lab values, right? Sometimes your LFTs bump, and that could be from oxali or dosi, or it could be from durva. And, again, we go through and, I won't bother you with the details, but we go through tricks of how to sort which one is which. But any grade adverse events, or surgery delays were not really that common. And again, durvalumab did not increase it. Neutropenia, other chemo stuff is what we see. And as I mentioned, fatigue, nausea, vomiting. So the practical aspects of care is that certainly immunotherapy can cause adverse events in any organ, right? You're taking the brakes off the immune system. But with anti-PD-1 therapy, it's relatively well tolerated. The most common adverse events are skin rashes, joint sort of discomfort, thyroiditis. They usually go hyper and then they go hypo. Liver function abnormalities that you may see on LFTs. The other one that's commonly underdiagnosed, especially by the residents and fellows, is adrenal insufficiency. So if the patient's coming in profoundly fatigued and like the blanket effect, right? They're like covering, they can't get up. Don't assume it's chemo side effect. Get a 7 a.m. ACTH and cortisol. You don't need to do any crazy cord stim tests, but you'll get an answer pretty quickly. So usually the patients with some immune adverse related events actually derive the most benefits. And for most grade 1, like skin, joint things, we continue to treat. If they have significant grade 2 effect, if you're not sure if it's immunotherapy or chemotherapy, we just hold the drug, repeat the LFTs 2 days later. And if the numbers are getting better without doing anything, it's not immunotherapy, it's chemotherapy. But if the numbers are still going up, they definitely need to be seen, and they probably need hepatologist. Usually ask them how many gin and tonics they had the day before, Tylenol, stop the, statins and things like that. But most of the time with steroids, all of the side effects go away. Grade 3 events, 4 events are rare. Definitely, needs an intervention, an admission probably for monitoring. The timing of these side effects is variable, but typically, if you don't get the side effects within first 3 months, you won't. In some of the melanoma studies, there's a late onset, but these are mostly CTLA-4 related. So with anti-PD-1 therapy, we don't really see like lingering side effects to the same degree. The neutropenia and GI toxicity and fatigue are probably the most common, and the best way to manage them is with dose reductions and growth factor support. I use prophylactic Neulasta or Neupogen with first cycle in all patients. So the 5-FU infusion is 24 hours. If they get treated on Wednesday, they get disconnected usually on Thursday, get a Neulasta shot. maybe a little hydration with a disconnect, and they're good to go. But giving patients Zofran, Reglan, all the antiemetics in their hands so they know to take them is a very powerful tool. So you got to and don't assume that, they understand what nausea is. Increasingly, actually, in our clinic and probably yours too, these are younger patients who have never been sick in their entire life. So they don't actually know how to take medications. So you have to kind of go through it with them.
While we're talking about cases, answer some questions?
Sure.
Okay. All right, here we go. So, I thought I'd have a straightforward case, and then we talk about one or two fringe cases. So this is you have a 65-year-old male with 3-month history of worsening dysphagia. Anemia presents with a diagnosis of GE junction cancer, T3N1, G3. We're seeing more and more patients with signet ring and poorly differentiated cancer. Otherwise, relatively unremarkable past medical and past surgical history. But this is what the PET scan sort of looks like. So we have a very significant involvement of the cardia and the GE junction, and the molecular analysis, so the CPS of 60, which does happen more often these days, and then the MMR is proficient and the HER2 is negative. So before we ask these kind of questions, like what to do next and so on and so forth, there's some questions over here. So the optimum sequence of immunotherapy, chemotherapy in this setting. So, with Matterhorn these days, we are doing deflot first and then surgery and then going back. So what are your thoughts on what would be the optimum timing, at least from my standpoint, between immunotherapy and chemotherapy? Because I'm sure I'll have a different answer. The longer I wait to get them better, the better for me. But
yeah. So go back to the PET. Sorry, I missed it. Is this the case with the superclave lymph nodes or no?
No, that's it.
Okay, good. Yeah. So this is a pretty straightforward case. So usually, depending on the extension into the cardia, which sounds like he has quite a bit of it. If I see the patient on a Wednesday, usually they're already getting either, in the OR or with one of our GI colleagues, repeat endoscopy, so we can understand the extension of the tumor into the cardia, especially if there's a signet ring component, a poorly differentiated component. Usually one of our surgeons will laparoscope and put a port in at the same time. Take some pictures, do cytology. And, in 15-20% of patients, you'll have an unpleasant surprise of positive cytology. Or even if it says atypical cells, we know that's not good. With this guy, if CPS 60, that's good. I think typically these patients would have a great response. And given everything I see so far, hopefully the lap will be negative. We'll get them on Durvaflot, as you said. We typically can start therapy the next day, week after I see them with all of this information. And then, I'll follow them closely. There's always this new sort of, the most in question at the cancer meetings is whether or not we should do total neoadjuvant FLOT. And I think that's a bit too much for outside of a clinical trial. Most doctors and patients can get through 5 cycles of FLOT pretty safely. At 6th cycle is when the side effects really set in. And there's a, fine sort of balance between, compromising their chances of full recovery after surgery and maximizes response. So you have to find somewhere that golden middle. And usually we repeat a PET to understand if they're responding or not.
Oh, yeah. 5 seems so close to 6. The data on FLOT4 was that 6 was almost as good as 8. And so the idea that you can get through all of this is very appealing.
It is to you also,
so
right?
You're saying so you're saying that between 5 and 6 is when they fall off the cliff.
They tend to, even if, with all of our cheering and special nursing support.
So I think that the other question is that the people often ask us is that, depending on if you're the first person to talk to them or the second or third person. And in our institution, half the time I'm the first person seeing them because it's a coordinated appointment. And a lot of it has to do with who's available first that morning. So the first question they always ask, what is my prognosis? Am I going to make it? So with the current regimen, what do you tell your patients right now?
Yeah. So, what I tell them is that Googling and looking up any data is not going to be helpful. And the number one predictor of whether or not they're going to be okay is their response to therapy, but also their final lymph node status. And clinical lymph node status is, only so effective. So we would need to wait till surgery. I don't tell them any prognosis. It doesn't help them. I think with CPS 60 and being fit, he has a real shot at cure. And I just refocus the language on that. And of course, if he has no response to therapy and has terrible, 16 lymph nodes, the game is different, and then you could have that discussion with them there. But, the first 3 months in even the recovery, perioperative or postoperative recovery is really focused on, you have a chance of cure, and we're going to try to get you there.
Okay. So this patient ultimately did undergo a esophagectomy, and this was the final path. T2N1, and 2 out of 52 lymph nodes were positive. The rest were negative. Grade 2 response, R0 resection. So what would be the optimum time to go back? I mean, how fit do they have to be from your standpoint for you to start deflot now?
Yeah. Well, usually, their feeding tube is out and they see me. And, some of it is just getting used to their way of living and eating and sleeping. And the decision is really based on how their functional status is, what % of their body weight they lost, and if they're still losing their weight, or are they ready to, are they eating? Are they able to sort of live with their new equipment, so to speak? And then typically it's, 4 or 5, I see them 4 weeks post-op right after the surgeon sees them, and then give them a bit of a pep talk about what to do and what not to do, and then 2 weeks later they start. So 6 weeks is probably the golden kind of time, but sometimes, we push it. You don't want to start too early because then there's all these interruptions and so forth. And if they had a complication or still not fully healed, we have to push it. But most people start within first, 12 weeks post-op.
So just curious, so you say you take out the feeding tube before you start. Given all of that discussion about nausea and Zofran.
The feeding tube has to come out.
It has to come out, okay. In this guy who had deflot, had some response, not perfect response, what is the role of NGS in predicting?
Yeah. So I think, the people who benefit actually the most, at least if you believe the retrospective data, are these people with partial responses to peri-op therapy. I think sending Signatera at this point is counterintuitive, is intuitive but counterproductive. Because if you don't find ctDNA, that's fine, but then so what? You still need to give him treatment. He has 2 positive lymph nodes. And if you find ctDNA and try to clear it, if he doesn't clear it with FLOT, and then what? What are you going to do? So it becomes, unless he's part of a clinical trial where there's some escalation strategy or de-escalation strategy, in clinical practice, I find that these tests are not helpful and right now, and also can complicate patients sort of understanding what they need to do. And NGS also would only be useful if you're trying to implement some sort of MRD assay.
Okay. All right. So I want to talk about 2 cases that are sort of on the fringe of what, it comes up every so often, to be honest. These days, it seems like it's coming up every tumor board. So this is a patient that is 61 years old, GE junction cancer, T3N2, G3, and this is his PET scan. So he's got a node in his neck in the TE groove. He's got a distal esophageal cancer, a couple of centimeters above the GE junction, and then he's got a celiac left gastric lymph node that's positive. So before the era of immunotherapy, this would have been a no-go from a surgical standpoint. And and if this person had this profile of a PD-L1 of 23%, this is a real patient, MMR is proficient, HER2 negative, we're always wanting to give people the benefit of doubt. So question is, we know that as a disease, it's much more aggressive than the last patient we talked about. So what would, how would we approach this? What would we consider this more metastatic? How much time would we give him how much treatment would you give him to see if he behaves more to push him towards resection versus not? So how do you decide who goes to surgery and who just gets definitive therapy in this setting?
Yeah, that's a great question. And I think this is a very important topic and fruitful area of research. I think this is probably the most common type of case we discuss at our DMT with the group. And I think the number one mistake we see made, when people come back to see us from other, settings or in what we've seen published in literature, is that this whole time period, as you mentioned, is not factored in, right? Time is such an important part of this equation to understand what the disease trajectory will be. And so the only time we would resect these patients, and we have taken them to the OR, is almost a year after systemic therapy if there's persistent disease in the primary tumor. And again, with discussions over and over again, because he's a fit guy, and obviously, you know, these patients want to be aggressive. And I do think you're improving somewhat, you know, disease-free interval if you take them to the operating room, and also maybe chemotherapy-free interval. And then if they do recur, they recur elsewhere, but at least the primary tumor is no longer causing, you know, problems like obstruction and so forth. But most people will treat them longer, and usually with doublet therapy.
So how long? If you had to throw a number out, would you say 3 months, 6 months?
A year.
A year. Okay. See, that's
if they don't met out any 3 months and 6 months does nothing. We already know that from some of the flawed data, even with people with, you know, they will. I mean, it's just a matter of what you want to do, but I would not rush to surgery.
Because you know, when we go to surgical meetings, people talk about these things, and you know, I'm hearing 3 months, 6 months. We waited 6 months to a year before we would even think about this. But you know, in the surgical world, you know, you do it once. You know, you tell them that in my experience, this is what I do. You happen to do it twice, then you say time and time again, this is how we do it. So I'm just trying to get a sense of what this is.
Yeah, It's hard. I mean, I think the only people that we got, and then if you do it, you got to do it right. Then you have to do a neck dissection, an RP lymph node dissection. It's not going to be an easy surgery, you know, and these are usually staged operations. So, and I can tell you, I mean, unfortunately, most of these patients still recur, but they do recur later. So what we have, you know, considered is doing a local form of, we actually have a trial now opening for local form of injection, intratumoral injection of CD40 agonists to sort of do another debulking before, you know, but we'll see. Okay.
All right, last question, last scenario, and then we can end the seminar today. Okay, 72-year-old gentleman, which is something we see very often, is somebody who's in heart failure, multiple heart attacks in the past, no inducible ischemia on his stress test, but his EF is only 38%. And this is what it looks like now. He's got a cardiac cancer. It's not extending significantly into the stomach. And his profile is PD-L1 is 12%, HER2 3%, MMR is proficient. You know, and then he starts deflot, and this is what it looks like. So, you know, we have somebody who has no morphopaque, endoscopically looks perfect, bite-on-bite biopsies come back negative. So what, you know, with the onset of the Sano trial, which is the watch and wait, you know, which most people in North America are not comfortable with. I know that Wayne sometimes talks about it, MD Anderson, but most of us have sort of not gotten behind it. What are your thoughts on watching and waiting? You know, this person, you know, we can get him to the surgery, but obviously it's going to be a little rougher than the average person. Obviously, mortality would not be the less than 1% we're used to seeing. It may be 3 or 4% or 5%, but what should we do with this one?
Yeah, so it's interesting. So this tumor is HER2 positive, but he has a decreased EF. We have gotten those patients through anti-HER2 therapy with medical management, so it's not a deal breaker. But I think if we had seen him, we probably would have incorporated anti-HER2 therapy, and you know, then improved his chances of complete response.
We already had a complete response, at least from what we can tell.
Well, just you know, you got lucky, but I'm just saying, I'm just kidding. But so what would you do here? We have incorporated non-operative management, and you know, because we have a trial for this patient. Actually, we did. We're doing flood Pembro-Traz, and MD Anderson and other centers and MGBs participating. You know, I think if he's willing to do endoscopy, watchful waiting is also like a time commitment, right? Because you do EGDs, you do PET scans, you have to monitor them carefully. I think in that cases, I would use Signatera, MRD assay, perhaps. Okay. But I think it's a comfort level of the patient and the DMT, but I do think I would support that.
To summarize, I think that immunotherapy is the cornerstone of our GE junction cancer. If they're frail, I think that we need to have a discussion between oncology and surgery as to what can somebody realistically get through, and that's where multidisciplinary collaboration is important. You know, DFLAT is approved now; it's in the NCCN guidelines, and it's just probably made it in the end of August, if I recall correctly. Thank you all for attending.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from AstraZeneca. To access all materials for this activity, visit peerview.com/DPV860.